Okay, so today we're excited to have a TLU alumna, Aleesa Griffin. She graduated in 2016 and got her degree at UT Health, which at the time was UT Health Science Center, I believe. They've changed their name more recently. And she will tell you more about her career. So let's give a welcome back to Aleesa Griffin.
So, hi. I told them at lunch, I do really well with one-on-one. I get a little nervous with groups, so and just FYI. But so I'm Aleesa. I've been a PA since I graduated in 2018. I came to TLU and graduated May of 2016, and 2 weeks later started PA school. And that was my program was a 30-month program. Prior to coming to TLU, I was a nurse for many, many years. And then when my kids started school, I decided I wanted to do something different and started looking into different fields that would push me, would allow me to treat and diagnose patients in a different way than nursing did. And settled between nurse practitioner and PA. And there's a lot of reasons that went into why PA school versus NP, but that's where it ended up. So came to TLU, got a degree in biology with a minor in chemistry. The minor gets you absolutely nothing, but I worked my butt off for it. So no, that's okay. See, I will. Don't worry. I'll mention it. So I mention it as often as possible. And then applied to PA school while I was here, got in, and so forth. So I'm going to talk a little bit today about kind of that whole process. I don't really feel like I need to talk about undergrad because I feel like y'all are doing it. If we need to talk about that, then we can do that later. So applying to PA school, this, and I apologize again to those that I spoke to earlier, but I know that y'all have heard this a bajillion times, and I know that it gets preached to you by people that are older and you think are out of touch and don't know what they're talking about, but clean up your portfolio, your resume, and your public profile. They do deep dives. They will look at every form of social media. They will Google you in ways that you can't even Google yourself. They truly do look into this because they want the cream of the crop. PA school in and of itself is harder to get into right now than med school. And so when you are trying to be competitive and get into a program that is that competitive, you need to be elite. The class ahead of me in PA school actually had a guy who was accepted. He went through the whole process, was accepted, moved to San Antonio from out of state, and 2 weeks before classes started was sent home based on something that he had posted on social media. My class, similar instance, but we were halfway through didactic and somebody got sent home. No, I mean, there was no ifs, ands, or buts. There was no discussion. There was no warning. Like, your warning is now. So even if you think it doesn't apply to you, it does. Well, I meant to ask, how many of y'all are looking to go into postgraduate work, or studies? Thank you, Wayne. Okay. You should look into it. Start early. So PA school or PA programs use a central application process or service to apply to or apply with. And then each individual school also requires application, additional applications, et cetera. But I believe it opens April 1st. I don't think that they've changed it, and closes sometime in July. That's April 1st of your junior year. So you need to start now, if you're not already a junior, you need to be looking into what you need, researching the requirements, finding out for the PAs, for the programs, what are med school, PT, PA, pharm, I mean, it's all very similar, and different schools require different things. UTL Science Center would have saved me a lot of heartache, and probably Dr. Ruane a lot of heartache, if they had changed their requirements before I applied to not include organic chemistry 2, but they didn't. So now they no longer require OChem 2, but some of the other programs do. So if you're looking at it, and you're not going to apply to just one. If you're looking to apply, you want to make sure that you're aware of all those things. I had a student shadow me who took a genetics class at A&M that is not accepted by any PA school. So after graduation, had to take a genetics class that fit the requirements. They are particular. You want to be different on paper. So this is what we were talking about earlier, but being different on paper, you're in here with all different people who are in all different studies, who do all different kinds of things. Some of you may play sports here, some of y'all might do intramurals, some of y'all might have been in home ec in high school. And while you might have a common degree or similar degree plan, your plans for postgraduate might be different, as evidenced by the raise of hands. So when you're applying to schools like this, you want to look different on paper, because the only thing they're going to see when you apply is what you look like on this application. You want what is going to set you apart. For the first time in my life, probably the second or third day of PA school, I sat there realizing that while we were from different states and we were different ages and we were different genders and we had different hobbies and interests, on paper we all looked very similar. We all had the minimum, we all had the GPA to get in. We all had those requirements. We all had those certain things. We were very like-minded. And you realize for the first time you're in a class where everybody looks a lot like you-ish. So you want things that are gonna set you apart, whether it's your volunteer hours, it's your job, it's your extracurricular activities, those things. And they need to not all be science or medicine based. Volunteer for Habitat for Humanity, do a fun run that is addressed for kids, volunteer at your church or a local school. Those kinds of things are what's gonna make a difference. And apply early. You want, they start, while it opens on April 1st and closes in July, and I mean, any of these programs, they start pulling those applications. These schools don't wait till the close of applications before they start looking. They're looking at them and apply everywhere, within reason. Make sure it's somewhere you can actually afford to move to and physically go to, but don't apply to just the one place you want to go to. Interviewing. So the interview process for PA school was terrifying. So once you apply, then you wait and wait and wait and wait forever to get this call for an interview. I interviewed at UT Medical Branch and UTL Science Center in San Antonio. Both interview processes were very different. And I left both of them thinking they know nothing more about me. My one at UTMB was one-on-one, but so that's where you went into rooms or offices with different faculty members or whoever they had brought in to interview, and you had anywhere from 5 to 7 minutes. It was timed, and they asked you or asked me obscure, crazy questions. So if you were a tree, what kind of tree would you be and why? If they asked somebody else, like if you were a car, what kind of car would you be and why? Now, one of the other ones was, what are some of your weaknesses and how can you make them strengths? But that mostly they were weird. Like, I'm like, I don't know how they know anything more about me than when I walked in there. UTL Science Center, when I interviewed, and the entire time I was there, did Multimini Interviews, and I'm pretty sure they're still an MMI based. So that is similar, where they're all timed. You go into the offices. Ours, there were like 8 different scenarios, all 5 minutes long with a minute between. And they were, like one of them was a puzzle, like a mind puzzle you had to put together. Another one was a math test with conversions that you had to do. Another one was role play with a medical scenario, and all right, you're this person, here's your scenario, what would you do? Another, like a riddle. Another one was an essay. They were, again, I left going, I don't know anything about me, but apparently they do. And then if you get an interview, after you interview, avoid the social media platforms and quorums and all the places because there's gonna be that person that's like, so I was on the first weekend of interviews and I've already got a call and I got in. And then you're like, I haven't gotten a call. And then you just looking all the time. So then you got in. Truly, like drinking water from a fire hose. So PA school is modeled after the medical model. It's a condensed version of med school, slammed into, for me, 15 months of didactic. Ours was pretty much 8 to 5, Monday through Friday, for 15 months. That is not study time, that is not lab time, that is not going to the cadaver lab for A&P. I was telling Dr. Grove earlier, so the cadaver lab at UTL Science Center, when you're in anatomy and physiology, you're given special access on your ID badge that only works for the cadaver lab while you're in that class. But the cadaver lab is open 24/7. So there were many times, 3 o'clock in the morning, I was in there with the dead people. Because that's when you could get a body to yourself to study, and going at 4 o'clock in the afternoon was never gonna work. How long is your program? I said 30 months, more like 84 years. They vary. I don't think that there's any more that are 24-month programs. I just don't remember. Most of them are 27 months to 36 months. So yeah, it's a lot. So PA fields of medicine. What can you do? What if you go into, if you decide to be a PA? So all of these popping up here, I am in family medicine, which primary care. So aside from the surgical ones showing up, I do them. There are PAs practicing in every field of medicine, and any combination of these. One of my friends is a pediatric cardiothoracic surgery PA. So you can take any of these and combine them. Oncology, gynecological oncology. And then what can a PA do or treat? Well, these are all things that I've either done or do on a day-to-day basis. Other than that, I've not done brain surgery, nor do I plan to. About the only thing, really, that, so you practice medicine within your scope of practice, within your comfort level. So if you're not comfortable doing brain surgery, you probably shouldn't be doing brain surgery. If you're not comfortable removing a toenail, don't remove a toenail. So in my clinic, I love procedures. I love procedures. So there's a lot of other providers in my clinic that don't care for them, so they'll farm them off to me. Some of those are, I like removing toenails. So if you've got an infected or ingrown toenail, see me later. I cannot sign a death certificate in the state of Texas. That has to be an MD. And I cannot prescribe you morphine unless I work in a specific part of the hospital where that is. I mean, that's just, nor do I want to, so don't ask me about that later. There's approximately 150,000 PAs currently working in the US and the District of Columbia. We work in all different settings: hospitals, VA, outpatient clinics, inpatient clinics, prisons, the armed services, space. I don't know if you all have read anything about the most recent travel to space, but the medical person on board was a PA. She's pretty awesome. And currently in the White House, there's a PA that is on staff directly providing care to the first family. So a typical day for me. I use the word typical very loosely. With family medicine or primary care, I'm what's called cradle to grave, so I see everything. From my youngest patient so far has been less than 2 days old, or less than 48 hours old, and my oldest patient so far is 104. So everything in between, and literally head to toe. I get to treat, so you have to know a little bit about a lot of things. These are kind of my favorites, just people that come in and they're like, no, I'm fine, I have nothing. And I'm like, we just did a background on your pharmacy pickups and you have all these things.
Aleesa, are you at a clinic or a hospital?
I'm in a clinic. So yeah, sorry, I am primary care in New Braunfels. So my hours are see patients 8 to 5. But really they're like 24/7. Like I'm off today, but I'm not really off. I was calling patients before I came here today. And the amount of people when you start practicing medicine, and again, emphasis on practicing, because it's like going hunting. You don't go shooting. You don't go catching when you go fishing. Medicine, you practice. You throw a lot of things at a wall and see what sticks sometimes. But I just lost my train of thought. But yes, so, you become very popular with your family, with your friends, and with anybody that might have your phone number or your social media, your Facebook. You start getting messages from your Sunday school teacher when you were in the 8th grade, or literally. Or the cousin you haven't seen in 7 years, now all of a sudden has a question about a rash. Can I send you a picture? So one of the reasons I went into primary care, like I said before, I love procedures. I love the OR, I love surgery, I love the ER. Those were some of my favorite rotations. Because I like the fast pace, I like the adrenaline, I like the procedures, I like being busy and doing those things, and you get to see a variety of stuff in those settings. I did not like not knowing what happened next. So when you spend 12 hours with a patient, you run 2 codes on them, and then you clock out and leave. You don't know if they made it. You don't know if they ever got transferred to a room, or if they got shipped out, or what happened next. And it really bothered me. And it's, you might not go back for a week, so it's not like you can go back the next day and say, hey, what happened to Joe Blow yesterday? Those patients, that's it. So with primary care, I see, like I said, all ages, but I get to see full families. I say get to. Some of them I get to. Some of them I'm like, you should see. So no. I like that I see parents and grandparents and kiddos, and I know what happens, and there's that follow-up, and there's that knowing what happens next. So I don't get bored either. There's nothing, it's common, people ask me that first year, like, how's it going? I'm like, I'm not bored. These are just some of the things that I've done in the last 8 days. I went through my schedule and just picked, and a lot of them actually more than once, especially uncontrolled diabetes, uncontrolled hypertension, the C word over there. People like to people are afraid of the hospital. Even before COVID, people don't want to go to the ER. And it is really interesting to me. I had a patient drive his golf cart from the golf course over to my office. And it was probably my second month there. And I'm the only one. When you're new, you're not seeing all those follow-ups, you're not getting those patients, you haven't built that panel yet, so you're getting all the acute care. You're getting all the people that call in that morning, I woke up with a sore throat, I woke up with a headache, I have back pain, whatever. So this man drove his golf cart from the golf course, and I don't know how many of y'all have been to New Braunfels, but Land Park Golf Course is really, really close to the hospital. It is not as close to my office. And having chest pain. He didn't want to go to the ER, because what if it wasn't a thing? So he got an EMS ride, first class, right over, and he was having a heart attack. There was a joke in my practice, my first 4 months there, probably not my first month because I wasn't quite as busy, but my second, third, and fourth month, I didn't go a week without calling EMS. It was a lot. My third day there, I called EMS on a patient who came to the office, walked in, and we don't take walk-ins, but she walked in and was sweating and dizzy and not feeling well. Well, I mean, you can't not see them. And by 3 o'clock that afternoon, she had a pacemaker put in because her heart rate was 32. So they would joke that I was running an urgent care or an emergency room there in the office. The most times I've had to call is 3 in 1 week. So if you have chest pain or severe shortness of breath, don't call your family doctor, go to the ER. But yeah, so I get to do a lot of like a Lego in the ear, that's fun. Broken wrists, lots of anxiety and depression, skin cancer removal, leukemia. That was those are the not so exciting things. Dr. Google is not my favorite. But people know everything. They know even more right now. So I graduated December 2018, took a month off, started February of 2019, practiced for a full year until the big vid hit. So 1 year prior to COVID, and then the last 2 years have been pretty interesting. And there are a lot of people that know a lot about a lot of things, and they'll tell you. They come in with their grocery list, like of what this is what I have, and this is what I need, and this is how I want to take it. Okay. So a couple of case studies, because those are fun. These are just, I mean, like I said, I'm never bored. I see a lot of interesting things. I see some boring things too. Sometimes the boring things are like the time savers. You're like, thank you. Slam dunk flu. Like, you've got the flu, it's positive, bye-bye. Especially, I mean, not so much this now, but strep throat. You get a positive strep throat, yes. That's a 7-minute visit. They're out the door. Here's your antibiotics. Have a great day. So this was a woman in her 50s who presented with a lump in the groin. She said it had been there for about 2 weeks when she noticed it. No pain. No pain to the area or anything like that, but that was what her appointment was made for, a lump in the groin. So lumps in the groin, first, and she had a lump in the groin, but first thing you think is lymph node, and it was a swollen lymph node, and so then you're like, okay, well, what can cause a swollen lymph node? Your lymphatic system is your cleaning system, so they swell for all kinds of reasons. If you've ever had strep throat or mono, then your lymph nodes in your neck swell. You can scrape your knee falling off a bike and your lymph node, the closest lymph node can swell, which would be your groin. Injections. My COVID vaccine caused lymphadenopathy in my armpit for a solid week. So their job. So further discussion, just talking to her, I was like head to toe questions. Yes, fatigue, but who isn't tired? If I asked any number of you if you're tired, some of y'all are falling asleep now. I mean, yes, it's very subjective. Other than my 6-year-old ADHD patients, everybody's got fatigue. She had some constipation and felt full and bloated. She hadn't had a bowel movement in a week. And she had a little bit of an abdominal rash right around the umbilicus on exam that she hadn't even noticed. So constipation or any urogynecological issue can cause a swollen lymph node as well. So after discussing her presenting symptoms and what was going on, I got some labs. Why is she all of a sudden constipated? Let's check her white count. Let's see if her leukocytes or anything are elevated. And then treat the acute. So in PA school, they test you. On my boards, they tested you for all the zebras. Yeah, but rarely are you gonna see the zebras. So you wanna treat the most acute and typically common thing first, constipation. So treated her constipation, gave her medication, had her come back in 3 days to see if that helped, see what the labs looked like, and see what that lymph node was doing and if it had gone down any with improving her situation. So she followed up and her constipation had cleared. She felt way less full, but re-examined her and she had an abdominal mass that was hidden by how distended she was previously. So pretty significant, firm mass, which is never, I don't want to say it's never good, but when things that are not supposed to be there are there, they tend to not be ideal. She denied weight loss because you start thinking, okay, what's going on? So you're asking specific cancer questions, no weight loss. And she said, she was like, I've had some sweats, but she's mid-50s. Mid-50s woman, menopausal symptoms. Okay, she's like, I've been sweaty for 10 years. I don't know if it's any different. And she had a very busy personal life at this time, and so hadn't really paid much attention. So got abdominal imaging, and then I got to make a phone call. It's never good when your nurse knocks on your door. It's like the radiologist is on the phone, wants to talk to you right now. That's not ideal. And so I found out about 1 o'clock in the afternoon and had a full patient clinic. And you want to have your ducks in a row before you call people. Nobody wants to get a phone call at 5 o'clock and say, hey, we're pretty sure you have ovarian cancer. I'll get back to you on what we're going to do about that. So she had I think it was a 12 centimeter mass on her ovary. Before I called her, I'd called oncology and surgery to set up biopsy because cancer is not cancer until you have tissue, and get all that set up. We did tumor markers in the meantime. While we're waiting to get her into all these things, drew tumor markers. I mean, it was ovarian cancer. She underwent multiple rounds of major surgery, multiple rounds of chemo and radiation. She is now in maintenance chemotherapy, doing really, really well. Feels great. Her counts have all returned to normal. And it's been a 2+ year process. And now she's where she follows up twice yearly. So they're not always that. The ending isn't always like that, but she's a pretty special one. So we always joke about her constipation that became a tumor. So case number 2, I had a patient who was, again, a middle-aged female, late 40s, early 50s, who'd had increasing vision changes over a 1.5-year time period. She had diminished sight. So she went to urgent care, and they told her she was having a panic attack. So a month later, she went to an ER, and they told her she needed to see an ophthalmologist. She went to an ophthalmologist. They told her her eyesight, like there was nothing physically wrong with her eyesight. She had really crappy insurance. Sorry if I'm not supposed to say that word, but she had, and so the medical cost for trying to find this out and what was going on and why her vision was changing. She went to another urgent care, and this is over, like now we're like 6 months since her symptoms first started. She went to another urgent care who told her she had anxiety again and gave her a prescription for Xanax. So by the time I'd seen her, it had been 1.5 years since her symptoms started, and she had given up. I mean, she was like, nobody will listen to me. She was a new patient to our clinic. And she's like, but this is not in my head. The only reason she made an appointment to come in is because she'd run into her fence at home. She could not see. She was driving, could not see well enough to drive. And it scared her. She had young children and knew something wasn't right. So lots of runaround, and I want to emphasize that I am very aware that I'm not perfect. I miss things, I make mistakes, I'm human. This was a lot of different people making a lot of different mistakes on this poor woman. It took time. It took time to listen to her, to ask questions, to pay attention to the details, to dig deeper. It took my nurse and I about 3 weeks to get all the records from all these places. And this is a patient who made a 30-minute appointment. So 2 weeks into this, I'm at least 15 hours into this 30-minute patient appointment. I'm getting paid the same, it's not right. Like, that's not taking care of the person that's in front of you. So passing this off or making them continue to come in for follow-ups without knowing. So reviewed the records, and not one person. So 2 ER visits, 2 urgent care visits, 2 separate ophthalmologists because you didn't trust the first one. Nobody had ordered imaging. Not one brain scan. I'm like, change in vision. Sudden acute change in vision that's getting worse. Like, she got a mass on the brain, something. Look at this. So tests, and more tests. And mind you, again, this woman has crappy insurance. So I'm trying to do this on, as financially possible for her. And finding which labs are going to be cheaper, which imaging place is going to, if none of them took her insurance, so which one can she afford to go to? Well, that's too far, but I got imaging. Backing up, so when I saw her, full Neurocheck, I had her ambulate down the hallway. And with somebody that's got vision changes, you expect, they're gonna be unsteady. They might be like reaching out or looking for something. This woman was walking cattywampus. She's walking like this and hitting the wall, and like even when she felt for the wall, she's just kind of like something just wasn't right. So her full neuro exam, she had some decreased sensation in her left foot, and she had decreased motor strength in her left hand. So it's screaming either mass or MS. So got the imaging. The imaging showed lesions on the brain, consistent with what you would see with multiple sclerosis. In the process of trying to get her into neurology, again, that would take her insurance. And even there's a lot of specialists that won't take a patient cash pay. What? Like, I'm willing to pay cash, but they won't do it. They want you to have insurance, and then they want to be accepting your insurance. It is infuriating when you know what this person has, and you know that there are treatments available, and that she could have been treated 1.5 years ago, and you're tied. So while we waited to get her in with neurology, I did a lumbar puncture and to test her spinal fluid, and it confirmed the multiple sclerosis. She finally got plugged in, and we got her in, I mean, really, I think it was like the 7th neurologist we tried, and she is on infusion therapy, maintenance therapy. Her lesions are shrinking. She pretty much has lost all her vision in her left eye, like that. It's not coming back. Her right eye is better. She can't drive. But she has some feeling and sensation back in the left side. But it could have been different for her. Like if somebody else had just listened and taken the time. The Stickies. So the Stickies are, like I said, I get to see a lot of fun things. Like the Lego in the 4-year-old's ear this last week was hilarious. Well, how did that get in there? I was like, I don't know, you tell me. I mean, that was his words. He was like, I pull it out, and I'm like, did you put this in your ear? I don't know how that got in there. Did your sister put it in there? So the Stickies are those patients that stick with you. An alcoholic patient in their late 20s, who had been treated by a couple of other doctors for this, who told me, when I called them to consult, who told me, don't waste your time. It's not worth it. They're just gonna continue. Don't bother. That's not me. So when I met her, she made an appointment for a headache. Like that's what the schedule said. It's a 15-minute appointment for a headache. And I walk in and she is drunk with a drink, with a Tervis, that I'm like, okay, well, all right. Angry, I mean, she's drunk. She was sweaty, diaphoretic, and this is 8:30 in the morning. She's headed to work. She just wants her headache treated. So in and out of treatment, she went to one inpatient. She finally agreed. We tried outpatient treatment with medication. That did not go well. Then she tried to quit cold turkey. She had a seizure, fell into her bathtub, broke her nose, 2 black eyes, put a tooth through the lip. So then she was in the hospital. So then she decided to go to inpatient. She left inpatient. She tried outpatient with medication again. And then the second time she went inpatient, it worked. She had made the decision, and because that's on her. Now she follows up with me. It went from the patient that I would see her on my schedule and think, to now I look forward to it because she always makes her appointment for the day after she's gone to AA and gotten her most recent chip so that she can come and show me. And that's pretty freaking awesome. Kiddos with genetic issues, congenital issues, autoimmune issues, those are scary. They're scary for the kid. They're scary for the parents. They're scary in the waiting, because for those people, their whole world is what is going on right now with my kid or with me. And for me, or anybody else, like in what I do, you have all these other patients. And so you want them to feel like they're a priority. You want to make sure that they know that they're heard. You want to make sure you're giving them good care and that you're getting these things done urgently. But also, I see on average 100 to 120 patients a week. That's a lot of people to make sure they feel heard. Getting them plugged in, getting them taken care of. But then, like with the one before, when they finally do, and they're with the treatment that's working, and everything's so much better, and they come back and they thank you and they tell you you're the best PA they've ever seen. You think, oh, this is why I sat through organic chemistry. The cancers will always be the Stickies. lost count, sadly, on how many people I've had to call or bring in and tell them that they have cancer, breast cancer, bone cancer, skin cancer, blood cancer, lung cancer. I had a patient just the other day who had some abdominal discomfort, but it had been going on for a while. And so previously it had diverticulitis, got some imaging of the abdomen. Abdomen's fine, but found a mass in their lower left lung. So now you got to deal with that. Incidental finding, no symptoms of cancer. Suicidal patients. I see a lot of anxiety and depression. More so now than ever. These are hard. They're exhausting. They're exhausting for the patient. They're exhausting for the provider. I have done direct admits. I have called the police to come pick up patients and take them. Because when you are at risk of harming yourself, I mean, I appreciate it when they're honest. There's a lot of them that aren't. And you worry all night. These are the patients that keep you up at night. I didn't sleep for like the first 6 months. I actually saw one of the other docs there. I was like, I am not sleeping. I feel terrible. And she's like, you've got to let some of this go. Because it was all patient related. Did I do the right thing? Did I prescribe the right medication? I can't tell you how many mornings I went back in the next day and was like, oh my gosh, did I give them the right antibiotic? And double checked. And I'm like, okay, good. I told you about my pacemaker patient. Diabetic acidosis, so patient in their late teens, came in, had been to 2 different urgent cares, treated for UTIs because he had increased urination and thirst and was diaphoretic, and they had low-grade fever, so they ran a urine. Urine was, other than showing some ketones, but they're like, it's a big dude, it's fine. So 2 different treatments for UTI, and so I'm like, well, let's just get a sugar. His sugar didn't read on our machine, so got an A1C, and I can tell any of you later what an A1C if you don't know, but his A1C was 14, and his kidneys were shutting down. He had a 7-day stay in the ICU, but is now a very well-controlled, down to, as of this week, a 5.7 A1C, which is probably better than a lot of us in here, and doing really well. But he almost died. That was scary. I would be remiss not to mention it. I honestly went back and added this morning because I really don't want to, I am so tired of talking about it. I'm sure, like everybody, we all have COVID fatigue. But when you work in primary care, I've tested, I've treated, I've talked to hospitalists, intensivists, I've been to funerals. It has been a very long, and there are some COVID patients that are my stickies. Some of them are not. So what they don't teach in school, the follow-up on your labs, the follow-up on your testing, the follow-up calls from the patients, the phone calls that you make to patients, the phone calls you get from patients, the phone calls you get from patients' family members. I have a couple of patients that I'm like, you're my favorite patient, you're my favorite patient number 2. When I lost my first favorite patient, that sucked. It was very hard. It wasn't COVID, but it was, those are the things they don't teach you. The imaging, trusting a radiologist. I don't trust them all. They don't always read things right. This week I had a broken wrist. They said it wasn't broken. I was like, I'd really like to see those images. So you pull up the images and you're like, buccal fracture. I don't know a lot, and I don't pretend to know a lot about imaging because I did not go to school to be a radiologist. That might be the most boring job in the world. You sit in a dark room by yourself all day. It may work really well for some people, but oh my gosh, it would drive me nuts. So getting the imaging and then knowing what you're looking at, or what the report says, or the incidental findings with lung masses and whatnot. There was a doctor that told me, like right after I started, he said, Aleesa, be careful what you go looking for, because you're gonna find something. So be careful what you order, be careful what you do, because like if you hear pneumonia, if it looks like pneumonia and you hear pneumonia, why are you getting a chest x-ray? Because you're gonna find something else, and you don't necessarily need to find, just treat what's in front of you. Because if you don't find something, you are gonna find something else. The tests and labs, like, oh my gosh. Up to Date is one of my best friends, because what do some of these mean? I have no idea. Researching, okay, so now their calcium is 12. I wasn't looking for that, but why is their calcium 12? Well, then you gotta go down that whole rabbit hole. I just wanted to know what their H&H was. So they don't teach how much time that all takes. The charting. Oh my gosh. Never in school, nothing, because when you're doing rotations, your supervising or your preceptor is the one that they've got a chart on their patient, and you might chart or help some. I'm sorry. You might help some on the charting, and I did a little bit, but nothing like when it's your own patient and you're having to signing off. So back to that 125 patients I see every week, that's a lot of charting. Especially in family medicine specialty, I'm a little bit envious because they have specific templates. When all you see all day long is skin cancers or derm or acne, and derm and acne and stuff like that, your notes start to look the same and you can just plug in different things. But when you have 8,000 different things you're looking at, it makes it a little bit different. And then admin, policy, staying current. I love medicine. I love it. And I frequently say, I still remember praying for what I have now and where I'm at now. And I am so thankful for that journey, but that is so not everything I have to do. If all I had to do was go into a room and talk to a patient and treat a patient, life would be golden. But staying current, staying up to date, making sure you're up to date with policies, making sure you know what, when the patient comes in and asks a question, you know what the actual they're talking about. And then the admin, we all have bosses, and there's a lot of good stuff that comes with that, and a lot of them don't know a lick about medicine, especially if you work for a hospital group or a large company or anything like that. If it is owned by other people that are not their business majors, they've never sat in a STEM class a day in their life past 12th grade, and they are telling you how to practice medicine. The other people that try to tell you how to practice medicine are pharmacists. I love the pharmacists. They are really good at what they do, but they stay in their lane. If anybody's squeamish, sorry, heads up. I have some fun pictures. Yeah, too late, sorry. So this is a teenager who put an axe in their leg.
And took a picture of it before getting to the ER.
Yes. Not the ER, me.
Oh.
So when that particular person got to me, you could see the bone. Look how good it looks. I mean, go ahead, right there. That's pretty good. That's some pretty good suturing right there. That's my kid. Older. That is skin cancer. That is one of 4 places I biopsied on this person. This person was a long-haul truck driver. Stuck his arm on that windowsill all day, every day, and skin cancer, hand and upper arm, because he didn't put sunscreen on, because why would you think that you need sunscreen if you're sitting in a truck? That is melanoma. That required way more surgery than what I do. I biopsied it and refer. We had a joke in PA school that what we primarily do is drop, kick, punt, like as often as we can, refer. So this is a mass, same person. This is their the back, like just on the shoulder blade there. I really wish I'd have taken a picture during and after, but it's really hard to do during and after, or during. And then after, you're like, I just want to go home. Like that was an 8-pound baby boy, I swear, we birthed that day, getting all of that out. It was about a 4 or 5 centimeter mass, about that much raised off the skin. It's hard to tell in those pictures. And it was a cyst that he'd had for a long time. I asked him if he named it. He had not, but it had become abscessed and infected, so draining that. That took about 45, 50 minutes to do. The back hides a lot of stuff. That's his tooth in his lip. But look how good. I didn't put the braces on or fix that. That got to refer. But this comes into me. Like, this is what I saw. I'm like, oh, okay, that ain't right.
Did he fall?
Yes, it was a bike. So I know you told me which one. I think maybe one of those.
Front ones.
Okay. So right there, that is not right. This bone should sit right about here in that groove. So they have fractured it like that. That was a step in a hole and fell. There's another angle. I drew an arrow for y'all. It's quite painful. That's a surgical repair. That was sent to pins and needles. Collarbone. What I realized in looking, I have a lot of pictures of rashes because rashes are hard. They are just hard, and so I send them a lot to take a picture and send it to my derm friend. But unless it's shingles, I don't love shingles, but shingles is another one of those slam dunk. They walk in and 99% of the time, shingles is so nice because it reads the textbook. Unilateral, looks the same, feels the same, done. But so I have a lot of pictures of x-rays because it's pretty easy to take that. And that's that right here. Ouch. That's a soccer, got cleated. This is awful. This is something you never want to see, and you never want to have to tell a parent, because that is osteosarcoma in a kiddo. That is bone cancer. Rashes, that is not a great picture, but this particular patient presented with, I don't think I have another one of that. So this part here had started probably about 10 days before she came to see me, and then had progressed and gotten bigger. And then by the time I saw her, so they brought in, she had taken pictures, and by the time I saw her, she had this diffuse rash all over. This is actually, she had 3 different rashes. She had an allergic reaction that was like dermatitis. She had a fungal, after we biopsied, she had a fungal reaction, and then she had erythema multiforme from some not her medication she was taking from a friend in her high school. Don't take other people's meds. Okay, sorry. This is a COVID lung. That's pneumonia. I don't know if y'all have ever seen a normal lung x-ray, but they should be black all the way around, like this area, not whited out like that. So, any questions?
First, let's thank Aleesa. Okay, questions.
If you go for it, yeah.
Yeah. So first off, thank you for all the information. That was really awesome to listen to. I did want to kind of jump to something that you touched on, kind of through the latter half when you were saying you know, the effect it had on like your ability to sleep and kind of like taking home some of the work. I just want to know what you would say is your best advice for those who are looking to the medical field who might have that same process.
And it's all individual, but finding a way to, you got to compartmentalize. You have to find a way to not take every situation home. For me, it's exercise and like being around people that are not in medicine. But it is hard, and it takes time too. I mean, I don't not sleep as much because of patients now, but it's a very personal, but finding something, whether it's, rock climbing or bike riding or going for a drive, it's music, not self-medicating. So those are not alcohol and not drugs. Those are not the ways that I would say cope with the stress that comes with it, but finding something in some way to plug yourself out is crucial, even in postgraduate school. So lots of kids, students, people, peers. I was still the old lady in PA school, so sorry. But a lot of them did intramural sports. So they were playing sand volleyball. And they were on it. They made a team and just doing things that were outside of the curricular. You have to.
Other questions? Do you think being a nurse helped you to be a PA?
Yes. Do I think it's critical? No, but I had a lot of, so I don't think it helped me with didactic. I truly believe that, and I said this earlier, and it's not just because my professors are in this room, but TLU really did help prepare me. What they expect of you here, and the difficulty level, and how you apply yourself, but that all depends on how much you apply yourself to. Helped prepare me. Not taking a break was huge, going straight from undergraduate to graduate. If I had had a year off, I guarantee you I would not have gone. But then once we got into clinical rotations, I was cruising. Like everybody else had to kind of find their footing and struggle, but I'm like, oh, this is where I shine. Like, y'all keep your AMP and what that innervates and everything else that's crazy about that stuff, and give me a live person in front of me. And so yes, I do think that it was advantageous. Also because I knew where the nurses came from. Be nice to the nurses. Be nice to the janitors. Be nice to the people that help you do your job. They are critical. So you can't walk all over them. So that I knew where they were coming from. I knew when they were frustrated. I knew why they were frustrated, and I could empathize with that. That helped.
Any other questions?
And I can hang out for a few minutes if y'all have any questions here. I realize that I am what's standing between y'all, many of y'all, and your weekend. So been where you're at. Know that a lot of you have to be here because it's like credit, extra credit. Yeah, hit me.
So you mentioned that there were lots of decisions that went into NP versus PA, but why PA versus med school?
So I had 2 kids in elementary school when I started back at TLU. By the time I graduated TLU, I had a middle schooler and an elementary age kid. That was just not in the cards at that time in my life. Yeah, there's just no way. People ask me all the time, patients ask me all the time, so when are you going back to be a real doctor? When are you gonna go back to be a doctor? And I was like, 2000, never. I'm currently paying tuition again for my kid to go to college, so yeah, no med school for me. Plus, I can do a lot, so.
Okay, well, thank you very much.
You're welcome.